Our next presenter is Dr. Ahmed Shuaib. Dr. Ahmed is a pathology registrar at Shefa Al-Orman Hospital, Luxor, Egypt, and his presentation is entitled Always Look Beyond the Surface. It's a case under supervision of Professor Shamal Gohri, Associate Professor of Pathology at Faculty of Medicine, Ain Shams University.
Thank you, Dr. Muhammad, for granting me the opportunity to present this case today, titled Always Look Beyond the Surface. Presented to you by me, Dr. Ahmed Shuaib, a histopathology resident in Shefa Al-Orman Hospital in Luxor, Egypt, under the supervision of Dr. Shaimaa Abdel-Raouf Al-Gohari, an associate professor and consultant of surgical pathology in Ain Shams University. And for starters, let's review the patient's clinical data. A 47-year-old female patient presented to Shefa Al-Orman Hospital with abdominal tenderness. She had a cervical mass that was diagnosed elsewhere as a metastatic bronchogenic adenocarcinoma. A PET CT was ordered. It revealed multiple hepatic focal lesions, the largest of which measured about 3 centimeters, with low-grade fluorodeoxyglucose uptake. It also revealed multiple pathological lymph nodes. Otherwise, no abnormal fluorodeoxyglucose uptake could be detected all over the rest of the patient's body. An ultrasound-guided biopsy was obtained from the hepatic focal lesion. Examined sections revealed cores of liver tissue infiltrated by a tumor formed of polygonal epithelial cells arranged in nests, groups, and trabeculae, surrounded by a moderately desmoplastic stroma. Tumor cells are mildly pleomorphic, with round to oval nuclei, inconspicuous nucleoli, and abundant eosinophilic cytoplasm. Keeping the previous diagnosis in mind, an immunohistochemistry panel was ordered to confirm the location of the primary tumor. TTF1 showed nuclear positivity in tumor cells. Napsin A came back negative. It was repeated and it came back negative again. Now that the diagnosis of a bronchogenic adenocarcinoma is unlikely, we elected to explore the possibility of a thyroid origin. PAX8 came back negative. Thyroglobulin came back negative as well, eliminating the probability of most thyroid neoplasms. The cytomorphology of tumor featured stippled chromatin and moderate mitotic activity, suggesting the possibility of a neuroendocrine neoplasm, so an immunohistochemistry panel was ordered to look into that possibility. Chromogranin A showed diffuse positivity. CD56 also came back positive. Calcitonin came back positive as well. It is known that calcitonin is positive in medullary thyroid carcinoma, but still it can be positive in many other neoplasms, so we had to keep that in mind. And considering that TTF1 was positive, we were left with two options: a calcitonin secreting neuroendocrine neoplasm of the lung, or a medullary thyroid carcinoma. Upon literature review, we decided to order CEA to help us differentiate the two possibilities, because medullary thyroid carcinoma shows diffuse CEA positivity, while neuroendocrine neoplasm of the lung would show patchy granular staining. CEA was ordered and it showed diffuse membranous positivity, thus confirming the diagnosis of a medullary thyroid carcinoma. Further assessment of the thyroid gland was recommended, despite the fact that clinicians denied any thyroid gland findings. A thyroid ultrasound was performed and it revealed a right thyroid nodule. It was solid, showing iso to hypoechoic nodule surrounded by a hyperechoic halo. Similar findings were noted in a head and neck MRI. A fine needle aspiration was performed. Examined sections from the cell block revealed groups and clusters of enlarged cells with eosinophilic cytoplasm, irregular nuclear membrane, salt and pepper chromatin. Some cells were showing plasmacytoid features. For confirmation, chromogranin was ordered and it came back positive. Calcitonin was ordered and came back positive as well, confirming the diagnosis of a medullary thyroid carcinoma. Medullary thyroid carcinoma is a neuroendocrine tumor derived from C cells. Most cases are sporadic, although about 30% of cases are familial. They are associated with syndromes like multiple endocrine neoplasia syndrome type 2A or 2B and von Hippel-Lindau disease. Upon literature review, we stumbled upon a study published in the Journal of European Radiology. It compares the efficacy of different radiotracers in detecting medullary thyroid carcinoma via PET-CT. It revealed that 18-fluorodopa can be superior to fluorodeoxyglucose in this context, which is unfortunate because it's widely used. And as it states, it usually misses about 38% of medullary thyroid carcinoma lesions. So we had to keep that in mind. The take-home message from this presentation is that pathology is not only for establishing a definitive diagnosis, but also for planning and guidance of proper clinical investigations and management. And thus, that's why you should always look beyond the surface. Last but not least, I would like to thank Dr. Shayma El-Gohari for his valuable support and mentorship. And I would like to thank Dr. Muhammad Kamal for making this event possible. And thank you all for tuning in. And I wish you all a happy International Pathology Day.